There are some people. It looks like there's some people joining us, but we'll just give everybody a few more minutes. All right, well, I'll get started, and I'm sure more people will be joining us. But my name is Claire Healy. I'm one of the co-managers in the Smilow Cancer Genetics and Prevention Program. And thank you so much for spending your evening with us. This event is titled Covering All the Bases, Getting Men in the Cancer Screening Game. Please feel free to use the Q&A feature throughout the presentation to submit any questions that you may have. I'll be collecting them and presenting them to our speakers at the end of their presentations. So before we begin, I do want to introduce you to tonight's speakers. We have Dr. Veda Giri, who's a medical oncologist with a specialization in clinical cancer genetics. Dr. Giri is the Division Chief of Clinical Cancer Genetics for Yale School of Medicine, Director of the Cancer Genetics and Prevention Program, and Director of the Early Onset Cancers Program at Yale Cancer Center. She leads an integrated and comprehensive effort in genetic evaluation for precision medicine, tailored cancer screening, and hereditary cancer assessment. Dr. Giri has a vested interest to expand research to address the genetic evaluation needs across cancer patients and community populations. And Dr. Giri provides her expertise on multiple national committees, including the National Cancer Institute, American Society of Clinical Oncology, and the National Comprehensive Cancer Network. We're also very fortunate to have Carson Nestler, who is with us tonight. Carson received her Bachelor of Arts degree in biology at Indiana University, Bloomington. After graduating, she worked as a research technician at Northwestern University, helping to develop targeted therapies for leukemia. She then went on to receive her Master's of Science in Human Biology from The Ohio State University. She's a licensed and ABGC board-certified genetic counselor and has been with the Smilow Cancer Genetics and Prevention Program for almost 2 years. She's passionate about educating others about their cancer risks and optimal cancer screening practices and expanding access to genetic counseling and testing for those who may benefit from it. And last but certainly not least, we have Tanaya Shroff, who is a licensed and board-certified cancer genetic counselor in the Smilow Cancer Genetics and Prevention Program. She graduated with a bachelor's degree in biotechnology and received her master's in human genetics from Sarah Lawrence College in New York. She's passionate about providing her patients access to genetic testing and helping them understand their risks for inherited cancer syndromes. She provides genetic counseling services both in New Haven and at St. Francis Hospital in Hartford. So with that, I'll turn things over to Dr. Giri to provide a brief introduction to our program and kick things off for tonight.
Thank you very much. Thank you, Claire. It's certainly a pleasure to be here for this Smilow Shares event. Wonderful for all of you to join. We're really excited about this event. And what we wanted to focus on for this particular topic, the title being Covering All the Bases, Getting Men in the Cancer Screening Game. And the reason that we wanted this theme to be for males regarding cancer and cancer screening was because June is Men's Health Month. And so we wanted to center it around this topic, and so really have it be informative in this way. Our cancer genetics program sees patients in the New Haven area and also in the surrounding towns and communities as well. You can see our cancer genetics team here, which is actually also growing and to serve the needs of our patients and families. And so we really do see a wide patient population, and these can be patients that have cancers, that do not have cancer but might be at risk for cancer, have a family history of cancer, and we truly find our work very rewarding. And again, this topic for today will be around men's health and screening for cancers that men may experience, and also the impact on families from the factors that we're thinking of here. So what we're going to cover today are some of the statistics around cancers, some of the common cancer risk factors, and some common cancer types that males and their families may experience, thinking about this from non-hereditary risk factors, but also hereditary risk factors, and really just end with some tips and resources to think about takeaways as well. So again, thank you so much. We have two terrific genetic counselors from our team, Carson, Nestler, and Tanaya, Shroff, who will be leading the conversation going forward and giving the presentation. So I will turn it over to Carson and Tanaya. Thanks again for being here.
Thank you, Dr. Giri. So we do want to take a moment to just share that a lot of the forthcoming data that we're presenting, it's derived from individuals who are assigned male at birth, who mostly refer to or identify as men. So this presentation or this talk is really geared towards biological males, and we'll refer to them as men throughout the presentation. And we also do want to take a moment to just acknowledge that racial disparities do exist in cancer care. And there is data showing that people of color are less likely to receive optimal care. So Black men, along with Native American and Alaskan men, have the highest overall cancer mortality, which is about 18% higher than white men. And also Black and African American men are twice as likely as white men to die of prostate cancer and continue to have the highest prostate cancer mortality among all US population groups. And these racial disparities may exist due to multiple reasons, and there are probably reasons that we are not aware of as of today, but some possibilities are there may be bias in care delivery. There is potentially lack of diversity in oncology providers and research. There are also maybe concerns about cost and unequal access to comprehensive insurance. Also, there are certain social determinants of health that may be different, such as access to healthcare facilities, education, healthy food, safe home environment, having reliable transportation, and just clean air and water. And lastly, there can also be cultural differences in discussing these health issues, even among family members, as well as with healthcare providers. Okay, so what we do know at this time is when we look at the 2023 estimates for men to develop prostate cancer, or sorry, cancer of any type, these are the top 10 cancers that we know of. And the leading cancer type that we see is prostate cancer. So as of 2023, about 280,000 men are estimated to develop prostate cancer, followed by lung cancer, colorectal cancer, cancer of the urinary bladder, which is sort of followed by pancreatic cancer here, which is the 10th most cancer that's estimated to be developed in men. And if we think about how many of these cancers result in deaths, that's topped by lung cancer, followed by prostate cancer, followed by colorectal cancer, and pancreatic cancer, which sort of jumps up to the 4th position here. And we'll discuss, a lot of these cancer types in more detail as we talk more about this. So that is a lot of cancers, but a question that we very often get from patients is, are all of these cancers hereditary? And the answer is, in fact, no. Majority of the cancers, I would say about 70% of all the cancers we see are sporadic cancers. So these are cancers that may happen due to a combination of factors such as, lifestyle factors, environmental factors, things people are exposed to in their lifetime. We do have a group of cancers called familial cancers, which form about 15 to 20%. We're not going to focus too much on these familial cancers during our talk, but they're essentially clustering of cancers which may happen due to shared factors within the family. So that could be environmental factors, diets, lifestyles, and maybe even smaller genetic markers that we cannot pinpoint as of 2023. And lastly, we have a small group of cancers which are inherited or hereditary cancers. So that's only about 5 to 10%, so a very small piece of the pie. Now, when we think about which factors actually are associated with or influence cancer risk, we can sort of divide them broadly into these 4 categories. So starting with lifestyle factors, we can sort of think of using tobacco or alcohol consumption or someone's diet or having excess body weight or physical activity as a part of lifestyle factors. Another category would be environmental factors. So you could think of things like having exposure to the sun or virus infections or occupational exposures, things people are exposed to during their job. So they are a part of these environmental risk factors. Another category would be hereditary cancers, which is factors that you typically inherit from your parents. And we'll focus on this as well during the talk. And this 4th category here is a bunch of miscellaneous items or other cancers, which can include things like process of aging, certain medical conditions that can increase the risk of cancer among people, use of hormones, and we do have a lot of unknown factors, things that we just haven't identified yet. So which of these factors really influence cancer risk and cancer incidences, and how do they cause cancer death? So we're focusing here on the 4 common cancer risk factors, which are implicated very commonly and influence the risk of cancer. So the big one is tobacco use, and it's estimated that tobacco use causes about 30% of all the cancers we see. It causes about 90% of all the lung cancers we see, and it causes about 30% of all cancer-related deaths in developed countries. And this risk from tobacco use doesn't just come from cigarette smoking, but it also comes from things like using cigars or pipes or chewing tobacco or even secondhand smoke exposure. Another risk factor would be obesity, and it's actually estimated that obesity may account for about 14% of cancer deaths in men. Another common risk factor is lack of physical activity, and it's estimated that physical inactivity may actually account for about 5% of cancer deaths. Another big one is alcohol use. So excess alcohol use has been shown to increase the risk of multiple cancers, including oral cancers, esophageal cancers, cancer of the larynx, liver cancer, as well as colorectal cancer. So it's really best to limit alcohol intake to less than 1 drink per day on average for women and less than 2 drinks per day on average for men. Okay, so how many men really engage in these common risk factors? So here's some stats 101. So what we do know is that about 30.9% adult men consume 5 or more drinks in one day. About 13.1% men are current smokers. About 40.5% men have weight that places them in the category of being obese. And about half men, so about 51.9% of the men have been diagnosed with hypertension. And lastly, only about 28.3% men meet physical activity guidelines for aerobic and muscle strengthening activities. So before we jump into some of these common cancer types and discuss some of the hereditary risk factors, let's take a moment to really understand what genes are and how does having these hereditary risk factors influence cancer risks. So simply speaking, genes are the body's instruction manual that are responsible for controlling certain functions in the body. So you can have genes for your hair color, genes that determine your eye color, and there are genes called cancer prevention genes. And as you see here, these genes need to be spelled in a certain order. And you inherit these genes from your parents, and you basically have 2 copies of all of your genes. Now, when a person has inherited a mutation, which is essentially having a spelling error in your gene. So for example, the letter C here has been replaced by the letter A. So this is what's called a mutation, and having a mutation in a cancer prevention gene does not allow the gene to function correctly, and therefore increases the risk for that person to develop cancer as above that of the general population risk. And mutations are oftentimes also referred to as pathogenic variants. So you may hear that term often, but for ease of use throughout our presentation, we'll just use the term mutation here. And importantly, mutations can be inherited equally by both men and women, and both parents can actually pass down these mutations to their offsprings. Okay, so jumping into some of these common cancer types that we see in men, the first one is prostate cancer, and this is the most common cancer that's diagnosed in men. The average man has about a 12% lifetime risk of developing prostate cancer, which means that about 1 in 8 men will develop prostate cancer in their lifetime. But majority of these prostate cancers are diagnosed in men who are age 65 or older, and it's very rare for young men under the age of 40 to have prostate cancer. If we think about what routine prostate cancer screening is available, prostate cancer screening can actually be considered starting at the age of 45 or even earlier if someone has a family history of prostate cancer or has other risk factors that elevate the risk of prostate cancer. But the screening typically consists of a blood test called a PSA blood test and also a rectal exam that physically examines the prostate. Now, thinking about what are some unique non-hereditary risk factors that may elevate the risk of prostate cancer in men. One of the first ones is race and ethnicity. So prostate cancer is more commonly diagnosed in African-American men and in Caribbean men of African ancestry than in men of other races. Occupation can be a risk factor. So firefighters may actually be exposed to chemicals that can increase their risk of prostate cancer. And lastly, there are a few studies that have suggested a possible link between exposure to Agent Orange, which was a chemical used widely during the Vietnam War, and the risk of prostate cancer. So on the flip side, what are some hereditary risk factors for prostate cancer? So the names you see here, BRCA1, BRCA2, HOXB13, these are names of some of the many genes we know that can influence the risk of prostate cancer. So inheriting a mutation from one of your parents among these genes can elevate the risk of developing prostate cancer above that of the general population. So for example, men with a BRCA2 mutation can have a risk of about 20 to up to 61% in their lifetime to develop prostate cancer. For these men who have a hereditary risk, there is prostate cancer screening available, which may be recommended at an earlier stage and even at an earlier or more frequently as opposed to someone in the general population. And then having or knowing whether someone has a mutation or not can also tell them if there is an elevated risk of developing other cancers. So for example, someone with a BRCA2 mutation also has a higher risk to develop other cancer types like male breast cancer or pancreatic cancer. So moving on to lung cancer, which is the second most common cancer that's diagnosed in men. The average man has about a 6% lifetime risk of developing lung cancer, which means that about 1 in 16 men will develop lung cancer in their lifetime. And this number does include people who both smoke and also those who don't smoke. But of course, for people who smoke, the risk is much higher, whereas for those who don't smoke, the risk is a bit lower. Thinking about what routine cancer screening is available for lung cancer, it's actually recommended for people to have a low-dose CT scan for people who are between the ages of 50 and 80, who have a 20-pack year or more smoking history. So thinking about a pack year, a 1-pack year smoking history would be equal to smoking a pack of cigarettes for 1 day for a year. So a 20-pack year history could be defined as either smoking a pack per day for 20 years, or it could even be smoking 2 packs per day for 10 years. So someone between the ages of 50 and 80 who has a 20-pack year smoking history and who smokes now or has quit within the past 15 years could be eligible for routine lung cancer screening. Now, in terms of non-hereditary risk factors that contribute to lung cancer development, the biggest one or the leading risk factor is tobacco smoking. It is known that the longer you smoke and the more packs per day you smoke, the greater is the risk for developing lung cancer. And this risk, again, doesn't just come from cigarette smoking, but cigar smoking and pipe smoking are also almost as likely to cause lung cancer as cigarette smoking. Another risk factor for lung cancer is exposure to radon. And radon is a naturally occurring radioactive gas that sort of results from breakdown of uranium, which is present in soils and rocks. So it's a naturally occurring gas that's present outdoors, but outdoors the radon levels are diluted and they're not likely to be dangerous. But in indoors, sort of in enclosed spaces, radon can be more concentrated, and breathing radon in exposes your lungs to small amounts of radiation, which over time may increase a person's risk of lung cancer. So for example, one way to avoid that exposure is when you're purchasing a house, sort of making use of those radon detection kits to make sure the radon levels are within acceptable limits. Secondhand smoke is also a non-hereditary risk factor for lung cancer. So even if you don't actively smoke, if you are exposed to secondhand smoke, you're around people that do smoke tobacco, that can also increase the risk of developing lung cancer. And lastly, exposure to asbestos. So people who work with asbestos, such as people who work in mines or in mills or textile plants, places where insulation is used, and in shipyards, so all the places where you would find asbestos, they do have a several times more likely risk to die of lung cancer. And there is also data showing that in people who have a combination of these factors, so asbestos as well as tobacco smoking, their risk to develop lung cancer is much higher. Now, when we think about the hereditary risk factors associated with lung cancer, there are actually very few. So most lung cancers are not hereditary, and they're instead due to lifestyle factors and environmental risk factors that we just discussed. There's one gene, however, it's called the EGFR gene, which has been more recently identified. And we do know that inheriting mutations in the EGFR gene, they have been shown to increase the risk of developing lung cancer. However, the number of families we know that have EGFR gene mutations is small, and therefore we actually do not know the exact risk to develop lung cancer for individuals who have these EGFR mutations. So most lung cancers still remain non-hereditary due to the lifestyle and environmental factors. Okay, so I'll now turn it over to Carson, who will share the remaining information with everyone.
All right, so now we're going to switch gears to talk about colorectal cancer, which is the third most common cancer diagnosed in men in the United States. The average man has about a 4.5% lifetime risk, which means that about 1 in 23 men will develop colon cancer in their lifetime. We typically recommend that for a person with the average degree of risk of developing colorectal cancer, that they begin their colonoscopies at the age of 45 and repeat those colonoscopies at least every 10 years. The age of initiation can change based on the family history, such that if a person has a family history of colorectal cancer in a first-degree relative, we may recommend that they start their colonoscopies at the age of 40 and do those colonoscopies every 5 years. So the frequency of those colonoscopy recommendations may also change based on family history of colorectal cancer, or even a personal history of findings such as polyps in prior colonoscopies. There are some unique non-hereditary risk factors involved with colorectal cancer risk, such as certain types of diet. We know that a diet that's high in red meats or processed meats can increase a person's risk to develop colorectal cancer. Inflammatory bowel disease, or IBD, whether that is ulcerative colitis or Crohn's disease, can increase the risk to develop colorectal cancer as well. And then we know that American Indian and Alaskan Native people have the highest rates of colorectal cancer in the United States, followed closely by African American men and women. So race and ethnicity seem to have some influence on risk as well. The most common hereditary risk factor involved in colorectal cancer risk is caused by having a mutation in one of these 5 genes listed here, MLH1, MSH2, MSH6, PMS2, and EpCAM. People who have been born with a mutation in one of those genes are said to have a condition called Lynch syndrome. People with this condition have a significantly higher risk of developing colorectal cancer. Depending on which gene that person has a mutation in, their risk could be somewhere as low as 10%, but as high as 61%. So it's extremely important to know if someone has one of these types of risk factors so that we can be screening them appropriately for colorectal cancer, as well as these other types of cancers listed here. People with Lynch syndrome have a higher chance of developing other types of gastrointestinal cancers as well. And for women, their risk to develop uterine and ovarian cancer is also increased. There are also some other hereditary syndromes that increase a person's risk of developing colorectal cancer, but they may also develop many colon polyps in their lifetime as well. It's extremely important to know if someone has one of these hereditary syndromes because if they have a higher risk of developing colon polyps, particularly if that may be happening at younger ages than the average person, we would want to talk about changing their colonoscopy recommendations to start at much younger ages and to be occurring more frequently. So, for example, for someone who has been born with a mutation in the APC gene, which causes familial adenomatous polyposis syndrome, they may develop hundreds to even thousands of colon polyps in their lifetime. They have an increased chance of developing colon cancer as well as other types of cancers. People who have mutations in a gene called MUT-YH have an increased risk of developing colon polyps as well. So again, extremely important to try to identify these types of hereditary risk factors so that we can alter that person's screening recommendations appropriately. The fourth most common cancer diagnosed in men is that of the urinary bladder. The average man has about a 3.5% lifetime risk, which means that about 1 in 28 men will develop bladder cancer in their lifetime. Currently, we do not recommend routine screening of a person's bladder, but certainly if someone has an increased risk of developing urinary bladder cancer, we can talk about what types of screenings are available. So some of those unique non-hereditary risk factors that may increase a person's risk to develop urinary bladder cancer, include history of smoking tobacco, individuals who have worked in the dye, rubber, leather, and aluminum industries may have a higher risk of developing bladder cancer as well. The same thing can be said for painters and firefighters. And people who have high levels of arsenic in their drinking water may also have an increased risk to develop bladder cancers. We know that bladder cancer is about 4 times more common in men than women, so gender certainly plays a role and influences risk. We also know that there are certain populations that have a higher risk of developing bladder cancer. For example, it is far more common in white individuals than in African American, Hispanic, Asian American, Native American, and other people of other ethnicities and races. People who have had chronic bladder infections, kidney or bladder stones, or have had long-term catheter use have increased risk as well. Those who have been treated or exposed to radiation or have had certain types of chemotherapy treatments, and those who have certain bladder birth defects also have an increased risk. And then there are some hereditary syndromes that increase a person's risk to develop bladder cancer as well. So we talked about Lynch syndrome as it relates to risk for hereditary colorectal cancer, but those people with Lynch syndrome do also have an increased chance of developing urinary bladder cancer. So again, extremely important to know if someone has a syndrome like this, because we can talk about what types of bladder cancer screening is available for those individuals. The 5th most common cancer diagnosed in men is cutaneous melanoma or melanoma of the skin. Skin cancer can affect anyone regardless of their skin color, but we do know that the lifetime risk of getting melanoma differs in people of different ethnicities or races. So about 1 in 38 white individuals will develop melanoma in their lifetime compared to about 1 in 1,000 Black people. And then 1 in 167 Hispanic people will develop melanoma. The risk for each person can be affected by a number of different types of factors. Typically, because the average age of diagnosis for melanoma is in a person's 60s, we would often see melanomas diagnosed at older ages. However, melanoma is not uncommon at younger ages, and we do sometimes see people diagnosed even in their 20s and 30s. If your primary care doctor finds any unusual moles or suspicious areas on your skin, they might refer you to meet with a dermatologist who can do a skin exam. People will often go to their dermatologist to do routine full body skin exams. And sometimes dermatologists will use a technique called dermoscopy to take a look at spots on the skin more clearly than they can do with their naked eye. Regular skin exams are especially important for people who have a higher risk of developing melanoma. So that would entail people with a strong family history of melanoma and other relatives, or even people who have had melanoma themselves in the past. So there are some unique non-hereditary risk factors that can increase a person's chance of developing melanoma. One of the major risk factors includes exposure to ultraviolet or UV rays. Sunlight is the major source of UV rays, although tanning beds and sun lamps are also sources of UV rays. It's experiencing 5 or more blistering sunburns between the ages of 15 and 20 increases a person's risk to develop melanoma by 80%. People who have light-colored hair, red or blonde hair, light-colored eyes, blue or green, or fair skin that may freckle or burn more easily are also at increased risk. And then if a person has a family history of melanoma in other relatives, the risk for those individuals may be increased because they perhaps share a lifestyle with those relatives. Maybe they have frequent sun exposure because of that, a family tendency to have fair skin, or maybe a combination of all of these different risk factors. We also know that people who have many moles in their lifetime may have an increased risk of developing melanoma. So having moles in and of itself is not necessarily a problem. Most moles will never become melanoma, but someone who has had many moles is more likely to develop a melanoma, particularly if those moles have been atypical, or sometimes we refer to these as dysplastic nevi. A certain percentage of dysplastic nevi may develop into melanomas, although most never become cancer. And actually, melanoma does tend to, in some cases, arise even without a pre-existing dysplastic nevus. We also know that in the United States, men have a higher risk of developing melanoma than women, although this does vary by age. But we know that before the age of 50, the risk is higher for women. And then when individuals turn 50, the risk appears to be higher for men. So there are a few things that we can try to do, or at least recommend that people do so that they can reduce their risk of developing melanoma. So you may have heard this before about limiting sun exposure, avoiding tanning beds and sun lamps, watching out for abnormal moles. If there's any change in the moles that you've had, we recommend telling your doctors about that. Wear hats, sunglasses, protective clothing, the goal being to, again, limit your UV exposure. And use a broad spectrum water resistant sunscreen with high SPF. So that would be an SPF of at least 50 on a year-round basis. So not just in the summer. There are some hereditary risk factors that are associated with a higher risk of developing melanoma. Most melanomas are not hereditary in nature, but rather are caused by those non-hereditary risk factors that we just discussed. However, in some cases, people who have, for example, a CDKN2A mutation have a higher risk of developing melanoma. So that risk could even be as high as 76% in some individuals. Having familial atypical multiple melanoma syndrome, which is caused by those CDKN2A mutations, increases a person's risk of developing both melanoma and pancreatic cancer. So it can be extremely important to know about this type of risk factor so that if there's anything else that should be on your doctor's radar, they can know about that. There's a couple other genes that are, we're learning have some increased association with melanoma development, BRCA2 being one of them, but also these other genes listed below. As we continue to learn more and do more genetic testing, I'm certain that we'll find out about even more genes related to this. So the sixth most common cancer diagnosed in men is kidney and renal pelvic cancer. The average man has about a 2% lifetime chance of developing this. So that means about 1 in 46 men will develop kidney cancer or renal pelvic cancer. Currently, we do not recommend routine screening for people who have the average degree of risk of developing kidney or renal pelvic cancer. There are some unique non-hereditary risk factors that can put a person at a higher risk of developing kidney or renal pelvic cancer, such as having a history of high blood pressure, having a certain occupation that may lead to workplace exposure to benzene, mustard gas, coal tar, or even soot. Race and ethnicity may play a role as well, as we've seen that kidney and renal pelvic cancers are more common in Black men than in white men. And then having a history of advanced kidney disease, which would require dialysis, may increase risk, as well as having a family history of kidney cancer. There are some hereditary syndromes, albeit not the most common cause of kidney or renal pelvic cancers. But if someone has certain types of kidney cancer, particularly if they're diagnosed at young ages, so any age under 50, we potentially would be concerned about the possibility of one of these types of hereditary syndromes. So for example, people who are born with a mutation in the VHL gene have a condition called von Hippel-Lindau syndrome. And these individuals have a higher risk of developing not just kidney tumors, but also benign and cancerous tumors of other parts of their body as well. So if a person has one of these syndromes or another syndrome that increases their risk of developing this type of cancer, we can discuss the potential to undergo routine kidney screening. And we certainly would recommend that for those individuals with increased risk, any of these risk factors, non-hereditary or one of these hereditary syndromes. The 10th most common cancer diagnosed in men is pancreatic cancer. The average man has about a 1.5% lifetime risk, which equates to about 1 in 65 men developing pancreatic cancer in their lifetime. There's currently no routine screening that we would recommend to a person with the average degree of risk of developing pancreatic cancer. Some non-hereditary risk factors that are unique to pancreatic cancer include ethnicity or race. We've identified that pancreatic cancer is more common in Black men than in men who are Asian, Hispanic, or white. A high-fat diet may increase a person's risk to develop pancreatic cancer, as well as certain chemical exposures, including exposure to pesticides, benzenes, certain dyes, and petrochemicals. A history of chronic pancreatitis or pancreatic cysts may increase risk, as well as a history of diabetes. There are certain hereditary risk factors that can cause a person to have a higher chance of developing pancreatic cancer. For example, having a mutation in either BRCA1 or even more commonly, the BRCA2 gene causes a condition called hereditary breast and ovarian cancer. These individuals can have up to a 10% chance of developing pancreatic cancer in their lifetimes, particularly if that mutation is in the BRCA2 gene. These individuals have increased risk of developing other types of cancers as well, and would be eligible for potentially regular pancreatic cancer screening, which can sometimes be performed as part of a clinical trial and is really more so available to people who have an identified increased risk of developing pancreatic cancer. So if anyone has any of those non-hereditary risk factors that we just discussed, or if they have one of these hereditary syndromes, then we can certainly and would certainly recommend discussing the possibility to pursue pancreatic cancer screening with that person's doctors. So we talked a lot about the possibility that a person could have a hereditary risk factor, which is extremely important to know so that we can understand, how we can be screening a person for cancer. The goal of cancer screening is that if a person ever does develop cancer, we detect it as soon as possible when it's in an early stage and is therefore more treatable. While this talk is primarily focused towards people who have yet to develop cancer and thus are concerned about their screening practices, we do also know that genetic testing can inform how we treat cancer once it is diagnosed. There are certain drugs or treatments that have been created to essentially fight cancer cells while doing minimal damage to the normal cells in that person's body. These are called targeted drugs or targeted therapies. So physicians can use a genetic test result to determine if a person is more likely to benefit from certain types of therapies. So we thought we'd leave you with kind of a recommendation for a game plan. How can you move forward after hearing this information? If you have identified with any of these risk factors that we discussed today, particularly if you have any history of exposures to any of these types of things, we certainly recommend discussing that with your doctors as well as your family history. Did anyone in your family develop these types of cancers? If so, I would want to make sure your doctor knows about that. You may want to ask your doctors when and how often should I be doing colonoscopies, prostate cancer screening, and skin cancer screening. Are you eligible to do routine lung cancer screening? Are there any other types of cancers that you can be screened for? And what else can you be doing to lower your risk to develop cancer? So really taking an active role in this game plan. We'd recommend that people try to limit their risk factors, which is not always possible. There are some non-modifiable risk factors that we know of, such as age, race and ethnicity, and gender. But typically, we talk about limiting a person's alcohol and tobacco use can go a long way. Avoiding exposure to radon, asbestos, or other types of chemicals. Wear sunscreen if possible, and try to avoid UV ray exposure. Try to maintain a healthy body weight, maintain a balanced diet, manage your stress levels, perform routine physical exercise, and stay up to date on your vaccinations. Lastly, if you are experiencing any new symptoms, just tell your doctor, it doesn't hurt, and see what they have to say about that. So I recognize that, if anyone is out there looking for resources to try to help reduce their tobacco exposure and may need help quitting smoking, and the National Cancer Institute does have a free national information service with smoking cessation counselors, which are available to answer questions at the number listed here. There's also a free service to connect individuals with specific counseling and information resources within their state at the number listed here. And if you need help finding a specialist, whether that's a gastroenterologist, a dermatologist, or some other type of specialist that you aren't currently seeing, you're welcome to ask your primary care doctor or some other doctor that you are seeing, or you might want to follow this link here and see if there's anyone in the area that can be of service. So that's it for our presentation today. We are all here to answer any questions that anybody may have.
Well, thank you both so much for a wonderful talk. To our attendees, please feel free to enter any questions that you may have in the chat or the Q&A. But I'll start off by asking, maybe could you tell us a little bit more about how genetic testing might be performed for people who may be interested in pursuing that after seeing this presentation?
Sure, I can answer that. So if you are interested in doing genetic testing, we typically recommend that people meet with a genetic counselor or genetics provider to discuss how genetic testing could influence or impact your life personally. We usually go over your family history, your personal history, and then talk about which test is right for you and how can we get that ordered. But ultimately, we would do genetic testing typically on either a blood or a saliva sample So, we can see people in the office, if that's, we have genetic counselors across the state in different locations. We also see people through telehealth as well.
Great, thank you. And for people who've had cancer, what should they be telling their family members about their risk to develop cancer? Do family members of people who've had a cancer diagnosis definitely have a higher risk to develop that cancer themselves?
So great question, Claire. I would say it's always important to share information about a cancer diagnosis with family members. There's no guarantee. All we can think about is if a person has a family history of a certain type of cancer, if that cancer was influenced by that person's risk factors, whether that was something in their environment or their lifestyle, it's possible that maybe their family members have encountered those very same types of risk factors in their environment or their lifestyle, or even in their genetics, their DNA. So it's extremely important to share that information so that people can be informed and ultimately talk to their doctors about whether they can do any cancer screening.
All right. So I think that's it for questions. So thank you all so much for taking the time to join us, and thank you to our wonderful speakers.
Thank you, everyone. Thank you for joining.